This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs. Also, make sure to check out and subscribe to our YouTube original channel, UCTV Prime, available only on YouTube.
Good afternoon, everybody. Thanks for coming. This is the third year in a row that Dr. Vincenti has given me this topic. First 2 years, actually, this meeting came after our American Transplant Congress, and I was able to review the abstracts and also hear some of the abstracts, and so it made it a little bit easier. This year our meeting is in a month, so I just saw the electronic abstracts. So I actually changed the topic a little bit. I changed it to what's new, what's interesting, and what UCSF is publishing. So I changed it around a little bit. I thought I'd highlight some of the things that we're doing and either are in progress of doing or publishing, and I thought it would be interesting to hear what our own group is doing in addition to a smattering of other things. As you can imagine, trying to review a couple thousand abstracts and come up with 5 or 6 in 30 minutes that you all would be interested in is always tough. And I did poll my colleagues about what's new, what's hot from their perspective. Peter Stock wanted a picture of himself shown because that's what's hot. And everybody else who had their own interests shared. So I didn't have 5 hours to present. I owe you that one, Peter. This was the #1 abstract for the meeting, and it's the group from Northwestern who is presenting their data on what they think is a important new therapy for the development of what they call tolerance after mismatch HLA, disparate living donor kidney allograft. So as you know, there have been 2 groups in this country who have done publishing over the last 10 years about attempting to achieve tolerance or immunosuppression-free transplants. One is the Boston group from MGH, and the other is the Stanford group. And in those individuals, they have different approaches to how they might try to develop chimerism and then ultimately be able to withdraw patients from immunosuppression. The Stanford group is only using HLA identical recipients at this time, and it makes it a relatively impractical therapy. And so Northwestern, along with collaboration with Susan Ilstadt, who is a researcher who's been involved in this area for many years, and actually we did some of the studies back in the 90s with her, and her discovery of what's called a facilitator cell, have developed this protocol. They actually published this paper in their first 5 patients, and then what they presented was their 14 patients, and will be presented next month at our ATC meeting. So these were 14 HLA mismatched living donor pairs, and they had their particular conditioning regimen where they get total body irradiation prior to transplant. They get cyclophosphamide before and after transplant to eliminate some of the alloreactive cells, and then other conditioning agents prior to the transplant. Give them the kidney, and then after the kidney transplant, they infuse this slurry of cells that they call facilitating cell enriched donor-derived CD4 positive stem cell transplant. And so what's happening, they're mobilizing and isolating these facilitator cells, which are a population of cells which are characterized by CD8 positivity, but they lack the T cell receptor. And they're also in this population of cells, or this group of cells, have a lot of pre-dendritic cells. And the theory is this facilitator cells help engraft some of these primitive stem cells and allow them to engraft in the bone marrow of the recipient, and then allow that recipient to be chimeric with donor-related cells in the periphery. They start them off on TAC and MMF, they don't get steroids, and then they followed these patients, and then as they were able to detect both donor chimerism in the recipient as well as donor hyporesponsiveness, they started to withdraw immunosuppression. So of the 14, 13 were able to actually have sustained macrochimerism. Most of the other trials that have been published have microchimerism, or very small quantities of the donor-related cells, and they're not very long-lived. They only had one engraftment failure, and that was in a patient who was highly sensitized. Over time, they lost 4 macrochimerisms detectable in the peripheral blood, and they were able to show durable chimerism in 6 out of the remaining 10. And they only had a single loss of a patient who had a very atypical, and they didn't define what the actual viral infection was, but aplastic anemia sepsis, and lost the graft. And when they looked at these patients, and again, this is just off their abstract, they had a number of these patients with pretty good follow-up, and these first 5 were actually published, and they went through case by case. But they were able to determine, or be able to detect macrochimerism in a number of patients. And in those individuals, they were able to get them off of all of their immunosuppression. So they're defining a group of patients where, again, an HLA mismatched group of a living donor recipient pair, where they're able to successfully get these people off of immunosuppression. So again, very different than what we've seen in the past, very intriguing. Our own experience with this particular facilitator cell some 20 years ago was not as successful as this, but it's a little bit of a view of a new approach and a way to get engraftment and develop actual macrochimerism, which may be important for this particular way of developing tolerance. Just wanted to go with the DCAF study, and this is to follow on with David, so I don't have to actually introduce this group of patients. But this Mike Cheka is presenting this paper, and again, it's a long-term deterioration of kidney allograft function, and there's that 4,000 patient group from 7 transplant centers. And over 1,000 of them had a biopsy, and at that time of a biopsy for development of renal dysfunction, they were also having measurements of donor-specific antibody, HLA antibodies. And what they did was not only characterize how many donor-specific antibodies they had, but the intensity in which those antibodies were, and they're able to characterize it and quantify it. And what they showed, or what he showed in this abstract, is those people who had a biopsy at the time they had renal dysfunction and followed out their graft survival rate over time, those individuals who had renal dysfunction without the presence of any donor-specific antibodies did the best, and then with increasing numbers and overall intensity of donor-specific antibodies, their graft survivals diminished with time. And this is kind of confirming the idea that these donor-specific antibodies are playing a role in further causing graft dysfunction over time and are detrimental to long-term graft success. So what he showed is that not only was the strength an important predictor of graft survival when you have patients with dysfunction. Now again, this isn't looking at a population of patients, and I'll show you in the next slide just about what happens to people who get DSAs. But again, this is a subset of patients. They have dysfunction, and they can detect donor-specific antibodies at the same time. The interesting thing as well is one of the markers that we use and one of the definitions we use for donor-specific or for humoral rejection is a deposition of C4D in the peritubular capillaries, is the strength of the DSA correlated to some degree with the strength of the C4D deposition. And as those graphs showed you, the more you have DSAs and the stronger those DSAs, the worse your graft survival is. One of the things that we have trouble with is that we measure, or we have the ability now technologically to measure HLA antibodies, but not all HLA antibodies are the same. And one of the things that we're trying to come up with is there ways of determining, are some of these HLA antibodies more harmful than others? And we now have an assay that is actually looking at C1q binding as a surrogate marker for those antibodies' ability to fix complement. Because when we look at the injury pattern, when we look at humoral rejection, clearly the part of the effector arm of this response is complement deposition, which leads to tissue injury and graft loss. And so this is coming out of the CTOT-02 study that's sponsored by the NIH, and part of our patients were involved in this trial. And what was happening with this particular trial is that all these centers were screening subjects who were unsensitized, who had no pre-transplant HLA antibodies. And then they were following them, and we were enrolling them to determine how many of them over time developed donor-specific antibodies. And then at the same time, we were trying to see, of those who developed donor-specific antibodies, how many of those people had evidence by C1q assay that those antibodies actually fixed complements. And again, the idea of this assay was to determine whether or not this could be a surrogate marker for antibodies which were injurious. So again, I'm summarizing a abstract, and follow me here a little bit. So out of those 750 plus patients, only 78 of them actually developed donor-specific antibodies post-transplant. Again, a completely unsensitized population. So about 10% of those individuals developed anti-HLA antibodies. And of those 78, 41 also had, in addition to DSAs, HLA antibodies, they were positive for the C1q assay. 63% of them were class 2 only, 27% class 1, 10% had both class 1 and 2. When you looked at those individuals who had antibodies, but those antibodies were also specific for the donor antigens, 75% were C1q positive versus only 44% were C1q positive. So again, this idea that maybe there is more to it than just developing a donor-specific antibody, and this assay may help and determine whether these, if we're going to follow them prospectively, whether these types of antibodies that develop may be more injurious. And that was sort of a hint of that was in those individuals who had a positive C1q assay had more rejection than those who did not. So it's kind of an interesting way of looking to see, because if we are going to develop tools to try to abrogate the effects of donor-specific antibodies, we don't want to necessarily treat everyone, because all of the donor-specific antibodies may not be injurious to the allograft. And this may be a way of being able to monitor that. So it's a kind of an interesting study. The DCAF study is really starting to turn out a lot of data that's kind of helping us prospectively. Flipping over to what we're going to present at ATC, and Dr. Chandran's going to do it. So the next few sets of slides are just taking from our own group. As you know, all of our patients who can safely undergo a biopsy at 6 months now have what we call a management biopsy. And this was a study that Sindhu and Flavio put together. And as you know, we see a lot of activity on these biopsies. And what we're interested in determining is this inflammation either indicative of something that's going on that's going to cause graft dysfunction, or is this going to be predictive of future events? And Sindhu looked at the 380 biopsies performed at the 6-month time point. They were scored by BAMF. And of these 380, we actually had HLA antibody testing at the time of the biopsy. This is just a quick baseline characteristic, a usual group of patients, 57% male, 31% diabetic, about 20% of them are sensitized, about half of them got thymoglobulin induction, about half got Simulect induction. So again, this is sort of a summary slide of a patient. Now remember, these people are coming in for a biopsy and have theoretically stable function or normal serum creatinine values. We actually saw about 7% of them had, by PAMF criteria, acute cellular rejection. Another 20% had what was called BAMF borderline acute rejection. We found antibody-mediated rejection in 4 patients and a lot of inflammation. So almost a third of these patients had some form of inflammation. And again, not meeting the true criteria of tubulitis, where you actually see lymphocytes within the tubular basement membrane, but inflammation in the interstitium. The presence of class 1 DSA was of 17%, and class 2 DSA was about 26% of patients. And when you just looked at inflammatory scores, this was associated with a lower calculated GFR at 6 months in those who did not have inflammation. And that de novo DSAs were associated with a higher risk of rejection and inflammation. And so, again, trying to draw some of these things that we have available both from an observation standpoint, but also potential future targets of trying to abrogate this process, which we think over the long run is going to be deleterious. And part of what's going to come out of this study is now we're going to start to biopsy these individuals who have inflammation at 6 months and rebiopsy them at 6 months to determine whether or not we're going to see progression or new lesions that may be troubling to the allograft in the long run. This is David and Brian's paper primarily, and this was presented last year at the ATC looking at our data of using ciprofloxacin as a prophylactic treatment in the prevention of BK virus replication post-kidney transplant. So as you know, and we've presented at this meeting many times, BK nephropathy is a significant problem for us. And there was a paper that came out of a group from Boston suggesting that the use of ciprofloxacin may reduce the incidence of BK nephropathy post-transplant. The theory being is that ciprofloxacin affects the gyrases, which are important in helicase and DNA replication of the virus. And so, although it's an antibacterial agent, it actually has antiviral effects. This was a group of patients that are pretty typical. Again, the living donors, about 40% of the population, 60% deceased donors, the usual kind of demographics. And what this study was looking at is we decided at one point in time to add ciprofloxacin to everybody's regimen, and it was a dose of 250 milligrams twice a day for 30 days post-transplant and stop. And what David did was look at the individuals who, starting that day forward, was looking at their outcomes. And then we took 6 months going backwards and took the same group. And so what group 1 was those individuals in the preceding 6 months who did not receive cipro prophylaxis, with the next 6 months patients being in group 2 getting cipro prophylaxis. Busy slide. Basically, again, about 50% of them got thymoglobulin induction, about 50% got Simulect induction. And again, in terms of immunosuppression exposure, there was no difference between group 1, which got no ciprofloxacin, and group 2, which did for a month. And where we presented the data at the ATC 3 months ago was what we thought was a significant decrease in the incidence of BK viruria and BK viremia. And so again, looking at these 2 lower lines, this is viremia. And so this is group 1, no cipro, group 2, cipro. And again, at 3 months, it looked like there was difference, but over time and at 12 months, no difference. This is the group 1 versus group 2 in viruria. So you can see the percentage of viurias is quite significant. So over a third of our patients develop viruria within the first year post-transplant. And again, when you looked at the 3-month data, it looked like we had a signal suggesting that the use of cipro early might diminish the chance of viral replication, but clearly over time these lines are catching up and there's no statistical difference. And so we've now subsequently abandoned the use of cipro. And obviously one of the things cipro does help with is urinary prophylaxis for bacterial infections in the post-transplant first month. However, the issues associated with problems of tendon rupture, which we saw in a couple patients, is significant. And using these drugs, especially with steroids, is a bit dangerous. And so we've actually, as a result of David's work, we've given this a try, and we're now abandoning it as a prophylactic agent. This was a study that our transplant fellow just presented last week and was working with Flavio and talked about what happens to patients in delayed graft function and what does induction do. We know that delayed graft function has some impact in patients' early outcomes, but the data is now suggesting that in the absence of acute rejection, that DGF in and of itself doesn't necessarily impact medium-term outcomes. And so we've always been a center that has embraced thymocyte depletion. We used MALG back in the old days with delayed introduction of calcineurin inhibitors with the idea that you're allowing the kidney to recover a bit before you introduce a potentially nephrotoxic drug. And so we, in general, about half of our patients receive Simulect induction purposely because they're low risk for rejection and we don't want to expose them to depletion. But we got into a situation where we had a patient who was a low immunologic risk patient who got Simulect in the operating room, came out of the operating room, the kidney didn't work, and now we had delayed graft function requiring dialysis. And historically what we did was we converted them to thymoglobulin to allow us to give some time to allow the graft to recover before introducing a calcineurin inhibitor. Well, we decided that we wanted to stick to what we thought was best for the patient, and we opted to stop using thymoglobulin in those individuals who developed delayed graft function unexpectedly and still met the criteria to get Simulect induction. So we looked retrospectively, and again, we had a point in time where we changed our protocol. And so this is a historical patient group of 40 who got basiliximab in the OR, converted to thymo, with 30 subsequent to our change in protocol who just got Simulect and no thymoglobulin. Looked at how long it took them to recover, how long it took them to get to their nadir creatinine, did they have rejection, and were there graft losses and rejection. So in this basiliximab group, again, both groups were defined by having dialysis in the first week. Compared to those who got converted to thymo, interestingly, there was less hospitalization in the basiliximab group. The number of biopsies, because of the concern if the kidney wasn't working, were we going to be biopsying them more, was no different between the two groups. Again, small numbers, but the lowest serum creatinine that was reached in both groups was similar. As protocol, we got them on CNIs much earlier in this group. We felt like the thymo gave us a little more breathing room. There's a bit of a signal that's worrisome here. There's a little more rejection in the group that got basiliximab as compared to thymo. A busy slide, but what I want to show you is that the time to nadir creatinine was much longer in those individuals who only got Simulect and didn't get converted. And so the median time was 65 days compared to 47 days in the thymo group. But interestingly, it didn't require that many more dialysis treatments to make a clinical decision that they no longer needed dialysis. And so, again, it took them a bit longer to get there, but in terms of the dialysis need, it wasn't significantly different. So, it's an area that we want to explore further. I think we're a little concerned about if we don't give them a depleting agent with recovering DGF, they may be at higher risk for rejection. But again, the preliminary stuff shows that it may be safe in this population of patients not to expose them to a depleting agent in all cases. This is back to Peter. I just wanted to show this. This is a little bit old, but we don't all get published in New England Journal very often, and I have to applaud him on an incredible study that took a lot of time to complete and certainly write up. So this is his summary of the 150 patients who received a kidney transplant who are HIV positive. UCSF and other centers across the country enrolled patients, and they were followed over a course of 1.7 years. And just to give you a quick summary of what we saw in that HIV population is that the patient survival at 1 year was about 95%, graft survival, or patient survival at 3 years was about 88%. And here was the graft survival in the two groups, 1 year about 90% and 74% in the graft survival at 3 years. So when you just look at a Kaplan-Meier curve, here is this group of patients with their patient survival. This is the national database for all patients undergoing transplant. He used a comparator arm of a higher risk group of patients, the older population, showing their patient survival out at 3 years. Graft survival, again, inferior to what is reported in national statistics. But if you look at what might be considered a higher risk group of patients, looked very similar. So somewhere falling between the national population statistics and somewhat higher risk group. The thing that we've really struggled a lot with, and our concern always, and we've talked about this before in the meeting, is that in these patients who have HIV, we always concern about concerned about over-immunosuppression, and some of our protocols and some of our approach to patients has been to try to minimize the risk to patients and ended up with opportunistic infections. And really what we ended up with was more rejection as a result of it. So although they have this endogenous virus, their response to the allograft is actually quite robust, and we really need to think about upping our immunosuppression rather than backing off on it. And one of the things that was really important is that this therapy was not accelerating the HIV disease. And this patient population, when well selected, I think is a completely appropriate group of patients that can be transplanted safely. The challenge is always thinking about therapeutic drug monitoring with their multiple HIV drugs and how they interact with this cytochrome P450 system. But a really nice study. Peter did a great job corralling everybody to do this in a really nice way. Wanted to talk just quickly about our Islet program. We also are, continuing on, and Andy and Peter are very active in the Islet program, and just wanted to show you that now Islet transplant is now, and I think we've showed this before, that Islet transplant is now actually providing survival nearly equivalent to whole organ pancreas. And so these groups, especially when you're looking at TNF alpha blockade with T cell depletion, are getting results out at 3 and 5 years that are pretty close to what whole organ pancreas transplant does. And these group of patients that we've been following with our own protocol using a combination of belatacept and Raptiva when it was around has been very successful in prolonging insulin independence over many patients. And again, some of these people have required more than one Islet transplant, but we have a number of patients out many, many days after Islet transplantation completely off insulin therapy. So it's a pretty exciting application, and Peter and Andy are continuing to improve on it. One of the things that's kind of neat is that, as you know, we inject the islets into the portal system and they go into the liver. Well, that event seems to incite inflammation by the liver against the islets, and so some of the concern of islet survival may be where you put it. And Andy tells me they're looking at now putting it in the gastric submucosa and trying to administer locally anti-inflammatory agents, which may allow the islets to engraft better with less inflammation and less early destruction. And so stuff is still moving in that area. We're looking at patients who would fit these protocols and actively enrolling them in the trial. So it's an exciting part of our work. Flavio has talked about this drug before. I just wanted to show you. I'm going to call it CP690 because I can't say that word very well. Remember, this is a JAK3 inhibitor. JAK3 is an important component of the gamma fraction of many of our interleukin receptors. And so by blocking the gamma fraction, you inhibit receptor function and neutralize cell proliferation. And this was a trial that's going to be published. It's submitted for publication, looking at 330 first kidney transplant recipients, 2 doses of CP690 compared to cyclosporin with basiliximab, MMF, and steroids. What they saw in these 2 different groups of what they call moderate intensity or lower intensity dosing arms is that rejection rates were pretty similar. GFR was significantly better. CAN was less significant. And graft and patient survival were no different. As anything with these kinds of drugs, where you worry about is immunosuppression in opportunistic infections, more CMV, more malignancies, more PTLD. So it has some interesting qualities, but when you start blocking a common pathway through multiple receptors, you may be getting into situations where the side effects, at least in terms of viral and malignancy potential, is much greater. And so I think a drug that has some role, but it's going to need some further work. So this was an article in the paper that you may have saw, and I'll finish with this one, that this was in a situation in Chicago where a living donor transplant had recurrent focal sclerosis. The recipient agreed. I don't know how Lorenzo convinced them, but they took the kidney out of the recipient and transplanted it into somebody else, and it worked. So Dr. Vincenti's life passion, apart from wine and travel, is recurrent FSGS. And you know, we've always talked about it here. You guys have known we worry about the permeability factor. We've been looking for it. Jutta Birnbaum was injecting rats 20 years ago in their into their renal arteries with serum from patients, and so we've been chasing it. And as you know, the Nature Medicine paper has found this putative agent, or at least something that seems to be associated with the disease, called SUPAR or UPAR. And they showed very nicely in this paper that was published last year that the serum values were higher in FSGS and not as high in other nephrotic syndromes, and also higher in patients who had recurrent FSGS after transplant. And they showed that when you plasmapheresis these people, you can reduce the serum circulating factor, and it's coincident with the reduction in proteinuria at the same time. This UPAR is an interesting molecule that has multiple domains. And what it seems to do is it interacts with beta-3 integrin to affect kidney podocyte effacement. So this attaching to the integrin, and Flavia gave me a nice cartoon. Here comes UPAR, there goes the podocyte. Now you give an antibody to this interaction, and there goes the podocyte. Magic of cartoons. So what we think is that by this interaction, by developing antibodies, or potentially just removing this by column depletion, but more importantly, I think by antibodies, that preventing this interaction between UPAR and the beta-3 integrin may in fact be able to resolve what we see as podocyte effacement, infusion, and potentially reverse the disease, not only in primary kidney disease, but may be very crucial in those people undergoing transplantation. And he has a whole project involved with the folks down at Mission Bay, as well as Pfizer and Pharma, to develop some more proof of concept, and then also start to look at this in patients who are awaiting transplant with FSGS. So I'll end there, and I know I'm way over, but I thank you for your time.